Hi students, hope you're all doing good. In this video, we are going to discuss one of the important topics for your clinical practice as well as for your exams, that is diabetes in pregnancy. Okay. Now we all know diabetes is a common medical disorder, right? So this is a diabetes is a common medical disorder. And if you see the prevalence of diabetes in pregnancy, it is around 10 to 14%. Okay. So the prevalence in pregnancy is 10 to 14%. And among this, if you take among this 10 to 14%, okay, 90% of them are going to be gestational diabetes mellitus. Okay. There are so many complications. Okay. It is not about the type of diabetes mellitus, but there are so many complications that are going to come for the mother as well as for the baby. Okay, during pregnancy, during delivery, as well as after delivery. Okay, so management, diagnosis, and follow-up is very important in a case of diabetes. So first we will start with some basics. We know pregnancy is a state of insulin resistance, right? Then there is fasting hypoglycemia as well as, yes, very good, it is postprandial hyperglycemia. Okay. Now, why does insulin resistance happens in pregnancy? It is due to various hormones, right? So, insulin resistance in pregnancy is due to various hormones like number one is human placental lactogen. So, this is the very important hormone that is leading to insulin resistance in pregnancy, right? So, it is human placental lactogen. Then, the hormones estrogen, progesterone, okay, and cortisol, okay, prolactin, okay. So, these are some of the hormones that are leading to insulin resistance. Clear? Now, we'll see why there is fasting hypoglycemia. Okay. See, there is fasting hypoglycemia because the fetus is a parasite. Okay, it is going to feed on the mother continuously, whether the mother is getting food or not, whether she is energetic or not. This parasite is going to suck all the glucose that is from the mother. Okay, so whenever she is already fasting, okay, she hasn't taken food for more than 8 hours, that is known as a fasting state. So in that state, if this parasite is going to take all the glucose from the mother, then what is going to happen? Definitely she is going to be in a state of hypoglycemia. Can you understand? Yes. So, the fetus continues to feed on the mother in fasting, and this doesn't stop even if it is a starvation. Okay. So, what it will lead to? It will lead to production of ketones. Okay. So, there is production of ketones by the mother if it is a fasting in a starvation state if it's happening. So, that will lead to ketosis. Okay. And in the state of ketosis, what will happen? Amino acids and free fatty acids are also used. Okay. First glucose is used. If that is over means amino acids and fatty acids are also used. Can you understand? So, in this case when free fatty acids are used, that means there is a state of ketosis. Here, sorry, repeat. So, what is going to happen is first the glucose is going to be consumed. And suppose there is a state when glucose is over means, okay, what the mother is going to do? The mother is going to consume amino acids and free fatty acids. When she is using free fatty acids, there is increased production of ketones and that can result in a state of ketosis. Clear? Now we will pass on to the next one, that is postprandial hyperglycemia. Now tell me simple one, why there is postprandial hyperglycemia? Because there is, yes, very good, it is due to insulin resistance. Simple. Yes? Okay. Now, with this, I want you to discuss about one hypothesis. Okay, to understand the overall concept of diabetes, we'll see what is hypothesis, that is repeat. So, now understand this concept and how it is going to affect the mother and the fetus. We have to know one concept that is known as Peterson hypothesis. Okay, so it is Peterson hypothesis. Okay, so first what is going to happen? There is maternal hyperglycemia, which is going to cause fetal hyperglycemia. Okay, then there is increased response to insulin in the fetus if this is happening. So, that will be leading to increased neonatal fat deposition, then increased abdominal girth, okay, abdominal girth, and also there is increased birth weight of the baby. Clear? So, this is Peterson hypothesis. Okay, I hope now you would have understood what is happening actually in the mother and how it is going to affect the baby. Okay, so now with this understanding, we'll move on into the actual topic. Okay, so if we see diabetes in pregnancy, okay, it is classified further into a diabetes which had started even before the pregnancy was confirmed. Okay, that is known as, yes, pre-gestational diabetes, and a diabetes which was confirmed in pregnancy, that is gestational diabetes. Okay, so that is gestational diabetes. Clear? We all know pre-gestational diabetes is again divided into two types. Yes? Yes, it is type 1 and type 2 diabetes, right? So, we have the type 1 diabetes and type 2 diabetes. This is a insulin dependent diabetic mellitus and this is a non-insulin dependent diabetic mellitus. Okay? And when you say gestational diabetes again, okay, so I can tell it can be a pre-gestational diabetes which is continuing in the pregnancy also, or there can be a new onset of diabetes that has arisen in pregnancy due to the various factors we have discussed previously. Okay, that is due to insulin resistance and the hormone actions. Okay, so gestational diabetes can further be divided into two types. Either it can be the pre-gestational diabetes itself, okay, that is continuing, okay, or otherwise it can be a true gestational diabetic mellitus that has arisen due to various factors. Clear? Now, we will see the pre-existing diabetes first. Okay, so if we ask me the pre-existing or pre-gestational, okay, in other words, you can also tell it is a overt diabetes. Now, I want you to know the cutoff ranges for diagnosing this. Okay, then we'll go to the discussion. So, we'll see the cutoff of sugar levels. Okay, see, for diagnosing this, the fasting blood sugar level should be more than or equal to 126 mg per deciliter. Then postprandial blood sugar, that is the 2-hour postprandial blood sugar, should be more than or equal to 200 mg per deciliter. Clear? And the HbA1c should be more than or equal to, repeat. And the random blood sugar can also be above 200 mg per deciliter, and the HbA1c is more than 6.5. Okay, so if these criteria are present, then it is going to be diagnosed as a diabetic mellitus condition. Clear? Yes. So ideally, pregestational diabetes means, okay, this is something that is diagnosed before pregnancy ideally, or even if it is diagnosed in the first trimester. Clear? So, before pregnancy or the first trimester. Okay, if the diagnosis is made, then it has to be pregestational diabetes. Clear? Now, we will see type 1 diabetes mellitus. So, type 1 diabetes. We know this most commonly occurs in young individuals, right? So, most commonly seen in younger individuals. What is happening in type 1 diabetes? There is absolute insulin deficiency, right? So, there is absolute insulin deficiency. Most of the times it is associated with, yes, very good, it is associated with weight loss. Okay, and in these patients there is very high plasma insulin levels. Okay, so there is very high, there is very high plasma glucose level in these patients. Okay, so very high plasma glucose levels. Okay, but this condition is not seen commonly, so it is less commonly seen condition, but the risk of diabetic ketoacidosis is high in these patients. Clear? Okay. Now we will go to type 2 diabetes. Okay, so type 2 diabetes is mostly seen in older age group. Okay, it is seen in older age group, or it can also be seen in a younger people with obesity. Okay, seen in younger age women or younger age people generally. Okay, younger age people with obesity. What is happening in type 2 diabetes? There is increased peripheral insulin resistance on beta cell. So, there is increased peripheral resistance for insulin in type 2 diabetes, and there can also be associated pancreatic beta cell dysfunction. Okay. So, first point is increased peripheral insulin resistance. Okay. Next one is pancreatic beta cell dysfunction. Okay. Clear? Okay. So, this is what you have to know about the pregestational diabetes types. Now, we will go on to the gestational diabetes itself. So, gestational diabetes mellitus. The definition is any degree of glucose intolerance that is first recognized in pregnancy and first diagnosed during pregnancy, mostly after first trimester. Clear? So, any degree of glucose intolerance with onset and recognition first time in pregnancy. Clear? And mostly it is diagnosed during second half of pregnancy, that is in the second trimester between 24 to 28 weeks. Now I hope you understand this point, because we have discussed this thing in physiology, because the levels of human placental lactogen hormone, which is going to cause insulin resistance, is going to increase during the second trimester. Clear? So, it is secreted only during pregnancy. So, when this gestational diabetes mellitus, that is happening due to the insulin resistance caused by the HPL hormone secreted in pregnancy, then it is known as gestational diabetic mellitus. Clear? So, that's why even if it happens in the first trimester, we are not considering it as a gestational diabetes mellitus. Okay, it is going to be a pre-gestational diabetes mellitus only if you diagnose the glucose intolerance or diabetic mellitus status, whatever, in the first trimester. Clear? The definition comes only if it happens in the second trimester. Be clear with this concept. Okay. So, we will see about the classification of gestational diabetes mellitus now. Okay. So, classification of gestational diabetes mellitus. Okay. So, we have class A1, that means it is a GDM with normal fasting blood sugar level. Okay. That means it does not require insulin, right? So, not requiring insulin. Okay. Next we have class A2. Okay. So, here we have GDM with elevated fasting blood sugar levels, that means requiring insulin. Okay. Then we have class B, where it is a overt diabetes mellitus. Okay. But the onset of the condition arises over 20 years of age, and the duration of the condition is less than 10 years. Okay. Next is class C. Okay. Here also there is a overt diabetic condition, but the onset is anywhere between 10 to 19 years of age, and duration is also anywhere between 10 to 19 years. Okay. And then we have class D, that means it is a overt DM. So, onset is before 10 years, okay, but the duration is more than or equal to 20 years. Clear? And also we have 3 more classes, that is classes E, that is overt DM with calcified pelvic vessels. Okay, calcified pelvic vessels. Next is class F, that is a overt DM with nephropathy. Okay, so it is overt DM with nephropathy. And also we have class R, which is overt DM with proliferative retinopathy. Clear? So, it is class R, which is over TM with proliferative retinopathy. Clear? So, this classification is known as white classification. Okay. But there is a newer classification called modified white classification. We will see about this. Okay. So, modified white classification. We have two types, that is class A1 and class A2. Okay. So, class A1 is a diet controlled condition, whereas class A2 is a medication controlled condition. Okay. And in class A1, the fasting blood glucose level is going to be less than or equal to 105 milligram per deciliter. Okay. So, definitely here it is going to be more than 105 milligram per deciliter, and 2-hour postprandial blood sugar is going to be less than 120 milligram per deciliter. Here this is going to be more than 120 milligram per deciliter. Clear? Now we will see the pathophysiology of GDM. Okay. So, if you take the pathophysiology of gestational diabetic mellitus, okay, first thing, there is insulin resistance, right? So, insulin resistance due to placental secretion of anti-insulin hormones, right? Especially, which is the important hormone? Yes, HPL. Second one, there is maternal hepatic glucose production, and this will increase by 15 to 30%. Why? To meet the fetal demand in pregnancy. Fetal demand in pregnancy. Okay. And number 3, there is a pancreatic beta cell dysfunction. Okay. It can happen due to various reasons, like due to genetics, okay, or due to autoimmune disorders, okay, or if she has a history of chronic insulin resistance. Okay, so these are some of the causes for pathophysiology of GDM in pregnancy. Clear? There is insulin resistance that we have already seen, and the maternal hepatic glucose production is also going to increase, and some other genetic condition, autoimmune condition, chronic insulin resistance conditions are also going to play a factor in gestational diabetes mellitus. Clear? So now we'll see the risk factors for gestational diabetes mellitus as such. Okay, so the risk factors include number 1, physical inactivity. Okay, physical inactivity. Number 2, when there is a family history of diabetic mellitus, especially the parents or the siblings. Okay, so there is a family history of diabetes, especially when it is father or mother or siblings. That means they are the first degree relatives. Okay, first degree relatives. Okay, and when there is obesity, okay, or there is a previous history of GDM. So there is a previous history of GDM. Not only that, suppose if she had a previous history of macrosomic baby also, okay, then also you have to consider her that she would have had GDM in her prior pregnancy. Clear? So, previous history of macrosomic baby also. What do you mean by macrosomic baby? Now for simple terms, you understand that the macrosomic baby birth weight in a previous history, if you ask, the birth weight of the baby would be more or less above 4 kg. Okay. And then she can also have hypertension, okay, or abnormal lipid profiles. Okay. So now these abnormal lipid profiles means either you have your HDL cholesterol less than 35 milligram per deciliter, and if you have your fasting triglycerides more than or equal to 250 milligram per deciliter. Clear? And not only this, there can be a history of PCOS. Yes, there can be abnormality in that, and acanthosis nigricans. Okay, which is again a sign of insulin resistance. And if you have HbA1c more than or equal to 5.7%. See, I told you the previously HbA1c more than 6.5. That means more than 6.5 means the condition of diabetes is confirmed. Okay, but here more than 5.7 means the risk for diabetes is increased. Can you understand the difference? Okay. Now, sometimes there can be impact fasting glucose levels, and there can be cardiovascular diseases. Okay, so all these are risk factors. Okay, and definitely Indians, okay, have a high risk for type 2 diabetes mellitus, that we all know. So, a universal screening is recommended in Indian women's. Clear? Universal screening for diabetes or gestational diabetes, whatever. Okay. So, you have to screen it definitely in the pregnant women. Clear? Okay. Now, coming to the very difficult part of the topic, but I have made it as much as simple as I can. So, we will see the criteria. Okay, you have different criteria also, different values also you have to remember, but we'll do it as much as simple in the way I can. Okay. So, first is, we'll see what are the different criteria we have for screening. Okay. We have the ACOG criteria. Okay. We have the IADPSG criteria, and we have the DIPSI guidelines. Okay. So, this is followed in India. Okay. And if you take ACOG criteria, this is a two-step approach. Okay. And if you take IADPSG criteria, it is a one-step approach. Okay. So, this alone you remember for now. Clear? Now, we will see one by one. First one is the ACOG criteria. So, already I told you it is a two-step approach, right? So, I will be doing two steps, right? So, in the step 1, I am going to do a repeat. So, in this I am going to do two steps, right? So, in step 1, I am going to do a screening, okay? And in step 2, I will be doing a confirmatory test, okay? And if you ask me, ma'am, what are these tests? The test names are, the screening test is GCT, that is glucose challenge test, whereas the confirmatory test is OGTT, oral glucose tolerance test. Okay. So, what is GCT? It is glucose challenge test. Okay. What is OGTT? It is oral glucose tolerance test. Clear? Now, we'll see how I am performing these two steps. Okay, for the step 1, that is for GCT, I'll be doing this test around 24 to 28 weeks of pregnancy. Okay, so it is done around 24 to 28 weeks of pregnancy. Okay, and remember, I can do this test irrespective of the last meal, that is fasting is not needed. Okay, so it can be done irrespective of her last meals, which means, yes, fasting is not required. And in this test, we are going to give 50 gram of glucose orally. Okay. And you have to check the blood sugar levels after 1 hour. Okay. Now, we'll see the ranges. Okay. So, if the range of blood glucose level is less than 140 milligram per deciliter, then she can be taken as a non-diabetic person. Okay. Then, if the range of blood sugar levels is between 140 to 200 milligram per deciliter, then you have to offer her the confirmatory test, that is step 2. Okay. So, do confirmatory test. And when sugar levels are more than 200 milligram per deciliter, definitely she is going to be a confirmed case of GDM. Clear? Yes. Now we'll see what we are going to do in step 2. Okay. So, in step 2, that is, I am doing OGTT. Right? So, in OGTT, this is actually a 3-hour oral glucose tolerance test. Okay. So, it is a 3-hour oral glucose tolerance test. Okay. But I will be taking 4 samples. Okay. So, 4 samples are taken. So, if you ask me what are the 4 samples, first one is a fasting sample. Okay. Then, I will be taking a 1-hour sample, 2-hour sample and a 3-hour sample. Okay. So, in this test, I want overnight fasting. Okay. Previously, overnight fasting is not needed. Okay. Irrespective of the meals, we are doing GCT. But for OGTT, overnight fasting is needed. Clear? So, we have to ask the patient to come with overnight fasting. Okay. And we will be giving 100 gram of glucose in 200 ml of water, or you can give it in lemon juice. Clear? Now, we will see the cutoff. Okay, this is the important part. So, for this, the cutoff ranges you should know. Okay, so we took 4 samples, right? So, the fasting values should be less than 95 milligram per deciliter. Okay, and the 1-hour values should be less than 180 milligram per deciliter. Yes, and 2-hour values should be less than 155 milligram per deciliter. And the 3-hour values should be less than 140 milligram per deciliter. Clear? So, we will come up again the OGTT values, reference ranges. Fasting less than 95 milligram per deciliter. And 1 hour less than 180 milligram per deciliter. 2 hour less than 155 milligram per deciliter. And 3 hour it is less than 140 milligram per deciliter. Clear? Yes. So, I want to make one important point here, like even, okay, even if any one of these values is elevated, okay, values are elevated, value is elevated, repeat. Now, I want to make an important point here, that is, even if any one of these values is elevated, then this can be diagnosed as a case of gestational diabetic mellitus. Clear? So, we will do the second criteria, that is IADPSG criteria. Okay, and I have already told you this is a one-step approach. Okay, so one-step approach. Okay, so what we are doing in this is, we will be performing the test at the first visit, or it can be performed at even the second trimester, that is between 24 to 28 weeks of gestational age. Okay, so this can be performed either at first visit or at 24 to 28 weeks of gestational age. Okay, and remember, for this test also overnight fasting is needed. Okay, so there should be overnight fasting, and what we are going to give is, remember, we are going to give 75, okay, it is 75 gram of glucose in 150 to 200 ml of water or lemon juice, whatever. Okay, clear? Now, we will be taking 3 samples in this. Okay, so 3 samples are taken. So, tell me what will be the samples? Fasting, yes, very good, 1 hour and 2 hour. Okay, now we will see the cutoff ranges. Okay, so if we see the cutoff ranges for IADPSG criteria, okay, don't confuse it with the previous values. Okay, so remember, this is for the IADPSG criteria. The fasting cutoff is 92 milligram per deciliter, clear, and the 1 hour value is 180 milligram per deciliter, okay, and the 2 hour value is 153 milligram per deciliter, and as I have previously told you, any one of the values is going for a rise, then it is diagnosed as a case of gestational diabetes mellitus. Even one value rises, then it is diagnosed as a case of gestational diabetes mellitus. And in this, I want to tell you one fact, that the 1 hour value will be same for both. Okay, the 1 hour value, if you see, it is going to be 180 milligram per deciliter only. Okay, but the fasting and the 2 hour values will change. Okay, not much difference, but listen. In the OGTT, it is 95 milligram per deciliter, whereas in the IADPSG, it is 95 and 92, right? And the 2 hour value is 155 milligram per deciliter, and here the 2 hour value is 153 milligram per deciliter. Clear? And we have a 3 hour value for OGTT, that is 140 milligram per deciliter, whereas we don't have a 3 hour value in IADPSG. Clear? So the reference ranges are also important. Clear? Next, we will see about the DIPSI guidelines. Okay, so currently this is being followed in India. Okay, so if you see the DIPSI guidelines, okay, so this is also one-step approach. Okay, so it is also a one-step approach. Okay, either at first visit or you can offer it at 24 to 28 weeks of gestational age. Clear? So, what you are going to do in this is, irrespective of the last meals, you are going to give 75 gram of glucose in water. Clear? So, irrespective of her last meals, you will be giving 75 gram of glucose and it is 3 ml of water. Okay, and remember, you have to ask her to complete this within 5 to 10 minutes. So, ingestion should be completed within 5 to 10 minutes. Okay, and you are going to measure the sugar levels after 2 hours. Clear? So, we will see the cutoff range. So, cutoff ranges for 2 hour values, okay, include less than 120 milligram per deciliter means that is normal. Clear? Then between 120 to 139 milligram per deciliter means she is in case of gestational glucose intolerance. Okay, so that is gestational glucose intolerance. Okay, and if the values are between 140 to 199 milligram per deciliter, then she is a case of GDM. Okay, that is gestational diabetic mellitus. Okay, then if the values are more than 200 milligram per deciliter, then she is a case of diabetic mellitus. Clear? Now, I want to tell one important factor. Suppose, okay, there is a chance that the woman may vomit if she consumes that within 5 to 10 minutes, okay, that first day. So, suppose vomiting is happening within 30 minutes means you have to repeat the test, okay, the next day. Okay, suppose the vomiting happens more than 30 minutes means you can continue the test. So, there is a pregnant woman. I am testing for GDM at her first antenatal visit. What is the grams of glucose I would have given? That is 75 grams of glucose, and we will be checking for 2 her blood glucose values, right? So, if it is going to be positive, that means more than 140 milligram per deciliter, then I will be managing this as a case of GDM. Okay. Suppose if it is negative, that is the 2R values is less than 140 milligram per deciliter, then I will be repeating the test at 24 to 28 weeks. Okay, I will be repeating the test. In that, if I get positive value, that is again the 2R ranges only. If it is more than or equal to 140 milligram per deciliter, then I will be considering this as GDM at this stage again. Okay. Suppose if it is less than 140 milligram per deciliter, then this can be managed as a case of normal pregnancy. Clear? Now, the advantage of DIPSI test is that it is simple, feasible, convenient and acceptable in Indian scenario. Okay? Because here we are offering only a non-fasting single test. Okay? That becomes more acceptable to the pregnant women if they are traveling for a longer distances. Okay? So, we are offering only a non-fasting single test that becomes more acceptable to the pregnant women since they have to travel more distances for health checkups in India. Clear? Now, with this we will complete this video. Until we meet in the next video, take care, happy learning and bye-bye.